It's 2 in the morning and you're pacing the floor. Your child woke up with a violent, racking cough echoing through the bedroom. In that moment, you face an immediate decision. Do you pack the car and rush to the emergency room, or do you ride it out at home until morning? Pediatricians will tell you a reality that completely contradicts parental instinct. A loud, terrifying cough is rarely the actual threat. The real danger to a child's life is usually silent. It comes from mechanical breathing failures, specifically from infections like pneumonia that cause the lungs to fill with fluid. When you rely on subjective listening, trying to judge exactly how bad a cough sounds in the dark, you are almost guaranteed to spike your own anxiety and misjudge the illness. Medical professionals don't rely on the sound. They use a completely different framework, the objective visual measuring of a child's respiratory mechanics. This chart shows the World Health Organization's clinical case management protocol. It uses a strict color-coded triage system, pink, yellow, and green, based entirely on a limited number of visual, mechanical signs, rather than a cough sound. Shifting your focus from listening to the cough to actually measuring the mechanics of breathing can save you from an unnecessary emergency room bill, and it prevents dangerous delays when your child actually needs help. The first step in this clinical triage is entirely objective. Count the child's breathing rate. While your child is resting or sleeping, watch their chest. Count every single time it rises for 1 full minute. You cannot guess or estimate. You need a full 60-second count. This is a standard pediatric intake matrix. Notice that before a doctor is even prompted to ask about the sound of the cough, they are instructed to count the breaths in 1 minute and check for general danger signs. This visualization maps the World Health Organization's thresholds for fast breathing. Under 2 months old, danger begins at 60 breaths per minute. From 2 to 12 months, the limit is 50 breaths. For children 1 to 5 years old, 40 breaths is the red line. Breathing rates spike for a very specific biological reason. When the tiny air sacs in the lungs become inflamed or fill with fluid or pus, the body has to work much faster to pull in the same amount of oxygen. A standard viral cold might cause a terrible, wet-sounding cough, but it will not push a child's resting respiratory rate over those age-specific limits. Hitting those numbers eliminates the late-night guesswork. An objectively high respiratory count is a definitive signal that home care is no longer sufficient. The second clinical test looks at what doctors call the work of breathing. To accurately assess this, you have to physically remove your child's shirt. You need an unobstructed view of their bare chest and neck while they breathe or sleep. You are looking for a primary mechanical failure known as retractions, sometimes called chest indrawing. This schematic shows exactly what a physical retraction looks like. With every breath in, the skin sinks sharply inward under the ribcage. When severe inflammation blocks the lower airways, the body recruits accessory muscles, physically yanking the ribcage to force the lungs open. You might also see the nostrils spreading wide open with every breath, a secondary sign of this extreme mechanical effort, called nasal flaring. If you see the skin tugging inward, it does not matter how quiet the child sounds. Visible abnormal chest mechanics are definitive proof of a severe infection or asthma. The final set of clinical tests looks for absolute oxygen deprivation and upper airway blockages. A standard wheeze is a high-pitched whistle you hear when a child breathes out. Stridor is a harsh sound heard when breathing in, indicating significant swelling in the upper airway. There is also the distinct auditory signature of pertussis, or whooping cough. This presents as a violent coughing fit, followed immediately by a desperate, high-pitched gasp for air. The most critical check bypasses sound entirely. You must look for cyanosis. This diagram highlights the specific assessment zones for cyanosis. You are looking for a bluish, gray, or dusky tint, specifically on the lips, the inside of the mouth, or the fingernail beds. The presence of cyanosis has a stark biological reality. It means the lungs are failing so severely that the bloodstream can no longer deliver sufficient oxygen to the body's extremities. Stridor and cyanosis are absolute physiological alarms. They bypass all other symptom checks and require immediate, extreme action. Once you have measured the respiratory rate, checked for retractions, and looked for color changes, you can map those symptoms onto a definitive triage matrix. This flowchart creates an actionable plan. The red zone includes severe respiratory distress, chest retractions, cyanosis, or stridor. This requires a 911 call or emergency room trip.
The yellow zone covers urgent threats, like fast breathing without retractions. The action here is a same-day clinic visit. Finally, there is the green zone. This is where a loud cough exists, but the breathing rate is normal, chest mechanics are smooth, and skin color is pink. The action here is home care. Navigating the yellow zone correctly saves your family from the chaos of a midnight emergency room visit, while safely securing a clinical assessment. For a green zone illness, the correct medical approach is hydration, honey for children over 1, and patience to let a viral cycle run its course. Medical guidelines strongly advise against over-the-counter cough suppressants for young children. They are unproven in this age group and carry risks of dangerous side effects. Applying this matrix transforms a 2 a.m. coughing fit from pure panic into calculated assessment. By replacing subjective listening with objective visual measuring, you reclaim control. You eliminate the guesswork, ensuring your child receives the exact right level of care.